Klaus, after we see his presentation, we will have a roundtable discussion. Looking forward to that. Thanks everybody for coming back for day 2.
So the estimation of the risk of radiation-induced leukemia and cancer after radiation exposure in utero is based on several independent major epidemiological studies. Yet, the estimation of the risks of impaired embryonal development potentially caused by exposure of pregnant women has exclusively been based on a single cohort of about 1,600 women in Hiroshima and Nagasaki who in early August 1945 happened to be pregnant and gave birth to viable children. The most notable published finding in the studies were clinical signs of impaired normal development of the brain, but among only those children who were in the early fetal period at the time of radiation exposure from the A-bomb. In this scatter plot, all children are indicated with their pregnancy week in the ordinate and their dose in the abscissa. Healthy children are dots. Children diagnosed with severe mental retardation are crosses. And it's clearly seen that the risk of impaired normal development is based on 25 cases of severe mental retardation, 25 crosses on this slide, 18 of whom were between week 8 and 25, when their mothers suffered from the effects of the A-bomb explosions, and some received a significant radiation dose up to about 2 gray, as they were close to the hypocenter. In the unexposed group of over 1,000 pregnant women who were far away from the bomb explosion hypocenter, severe mental retardation was diagnosed in 7 children. These are at the 0 gray exposure dose. In line with the established classification of embryonal development, cases exposed or non-exposed in week 8 to 15 and in week 16 to 25 were analyzed separately. There were 15 cases in those exposed to any dose in weeks 8 to 15, while there were only 3 cases exposed in week 16 to 25. From these observations, it was concluded that the embryos exposed before week 8 were radioresistant, the 4 lines at the bottom. So again, the embryos exposed before week 8 are radioresistant. Those exposed after week 15 were little sensitive to develop signs of radiation-induced impaired embryonal development, much less so than those in week 8 and 15. No mental retardation was diagnosed in 75 children exposed to less than 100 milligray in this group of 16 to 25, but 3 out of 8 children were retarded after exposure to more than 100 millisievert, milligray, sorry, an unexcusable mistake using sievert in this context. For the radiosensitive period, weeks 8 to 15, the absolute radiation risk in utero was estimated at 40% at 1 gray, as interpolated between the two dose groups, about 0.6 and 1.3 gray. However, the more than 100 milligray group has an incidence of 9 out of 12. That is 75%. There was a poorly defined dose threshold. I don't know how they arrived at the number of 30 milligray, but this is the generally accepted dose threshold. Yet the difference in the thresholds between week 8 to 15 and 16 to 25 is based on very small numbers, 3 out of 16 versus 0 out of 16. There are other problems with this presentation of the data. The diagnostic criteria for severe mental retardation have changed several times during the past 70 years. Moreover, the factors attributed to causing severe mental retardation are manifold, ranging from microcephaly to genetics to social deprivation and ostracism, from which particularly young women among the A-bomb survivors suffered. The relative contribution of the different factors to generate the phenotype of severe mental retardation is variable, and attribution to a particular cause uncertain. In addition to these data, RERF published results of an examination of 1,673 children at the age of 10 years. In contrast to the severe mental retardation study, the results were not published in the same detail, but only for the different pregnancy stages, mean values and confidence intervals were given, and this is the tabulated data. Overall, the results of both studies, severe mental retardation and IQ measurements, were similar, but there was no strong evidence of a dose threshold. The IQ decreased following a linear no threshold function, and this is the publication of ICRP, how they presented the data. The IQ decreased following a linear no threshold function at a rate of 1 IQ point per 40 milligray. And ICRP 90 declared this risk as negligible. In addition, school performance data were also obtained on 929 pupils at the same age of 10 in Hiroshima, and the results were similar to those of the IQ test. ICRP 90 presented both analysis of the results of both evaluations of intelligence, the severe mental retardation and the IQ, in the identical cohort, but did not make a clear choice and recommendation of how to use these findings in radiation protection practice. Should we regard the effects of in utero irradiation on human embryonal development of the brain to be a stochastic effect with a linear no threshold severity weighted dose response relationship, or a non-stochastic tissue effect with a threshold dose? This inconsistency of ICRP is a strong argument for sacking the traditional distinction between stochastic and tissue effects in the system of radiation protection altogether. This distinction has in the past too often resulted in unnecessary confusion. While the database for estimating the effects of in utero irradiation on the development of human embryos is very limited, there is a plethora of experimental studies on the effects of in utero irradiation on the development of mammalian embryos, mostly mice. In several large international symposia, the results have been presented, discussed, and their relevance for radiation protection been evaluated. And the first took place in Oak Ridge nearly 70 years ago, when presentations and discussions were published on more than 300 pages. It's still fascinating reading. Liane Russell, best known as the mother of radiation genetics research, presented in great detail her experiments on the radiation effects after irradiation of thousands of pregnant mice. She probably was the first to demonstrate that the nature of the radiation effects depended strongly on the stage of pregnancy, independent of the radiation dose. That means death of the embryo in the pre-implantation phase, all sorts of malformations in the phase of organ formation, no apparent effects in the fetal phase. And numerous studies since confirm this principle, and many other international symposia have been organized to describe all these data. Fascinating radiobiological experiments help to understand underlying mechanisms of radiation effects on neurocognitive function and brain structure. Arafi yesterday showed some beautiful examples. Yet little research addressed other effects also observed in mammals, such as skeletal malformations, neural tube defects, cleft palate, etc. The most commonly observed effects in rodents exposed in utero and are summarized as spina bifida. Much public anxiety was caused by reports on congenital malformation, mostly spina bifida or cleft palate, in some regions to radioactive contamination by the Chernobyl accident in the last 20 years, 30 years. These publications were generally dismissed by radiation protection scientists as unscientific. Even this were correct, and I probably agree. They point to an important problem. Why does radiation exposure in early human pregnancy not cause gross developmental damage, such as spina bifida, as it does in other mammals? Spina bifida may be induced by exposure to toxic agent at earlier stages of pregnancy than mental retardation. Is there any convincing explanation why this does not apply to radiation exposure of human embryos? I don't know. Thank you. Okay. Do you hear me now? I don't hear you.
Hello. That's better.
Hello.
Yeah.
That's
okay.
better.
Okay, Klaus, you can hear me now. Yeah. Okay.
Yeah.
So there was a problem there. Yes. Thank you. Thank you. That was very provocative and touching upon a very interesting set of issues. Yeah. Thanks very much for that. Are there any questions for Klaus?
Hi, Klaus. It's Rafi. I might don't agree with you about the fact that there is no threshold.
Uh,
Uh,
a threshold of what?
all the publications of Schul, they show always a threshold around 200 milligray of induction of cognitive.
Yeah, severe mental retardation, but
Yes.
not on IQ loss. That means
exactly that.
the threshold is not a question of the data. It's a question of how you use the data to produce your concept.
Right. I see. Good.
And this is not acceptable. Is a say, let's assume 50 or 60 milligray or so, and an IQ loss of two IQ points.
Yeah.
That may be important or maybe not important, but that's not for us to judge.
Yeah, please.
Yeah, Klaus, so you're saying there is no threshold for IQ effect?
That's at least what ICRP 90 says, and all the RERF says also. There is no IQ, no threshold for IQ.
Well, that's what I've been suggesting too from rereading these documents, and I've been wanting to bring it forward in a more strong way, but they suggested it. They didn't actually say it. They were very careful. So I don't think ICRP's had a very strong statement about it. But I'm glad you're bringing this up. I think it's something that I've wanted to say because it has an impact, or it would have an impact on our group D in terms of protection policy and medical imaging, which is my field, and trying to tell people to be more thoughtful in thinking about radiotherapy and imaging of pregnant women.
Yeah.
So thank you for that.
Because I think it's the only practical consequence of all these discussions is only related to pregnant women who go for diagnostic procedures, maybe a few cases of women with breast cancer who get post-operative radiotherapy. But the doses that are in the uterus in the early stages of pregnancy are so low, which have been examined in the Allegro project. So that it's the real problem is diagnostic radiology, and the doctor has to talk to the patient, and they don't know what they have to talk. If they show these slides, is the IQ not a problem? Is it only severe mental retardation? And what is severe mental retardation? It's a summary diagnosis which involves so many different things. More initially it was just IQ. In the meantime, it's social problems as well. So we should be careful here.
Yeah, I agree. We should be careful, and I think these parents want to know. But for like breast cancer treatment, it's about a 30 milligray dose to the fetus.
Yeah.
For radiotherapy.
Yeah, I know.
That graph that was shown, the IQ versus dose, and sort of some linear decline, the y-axis is mean IQ, which means it's very sensitive to outliers. And so whether or not you're going to, I think I'm not really familiar with those data, but I think that graph needs to be very carefully interpreted, because it only takes a few people to pull that mean down, and it wouldn't be a linear response at all.
I think we should reanalyze all data and put them in context. Everybody just agreed the old Schall dose-response relationship with a threshold which was just convenient for the radiologist, because a dose of 30 milligray is hardly ever exceeded in diagnostic radiology. I've been involved in quite a few of these evaluations, and they were all lower. And so I think it is a problem for the radiological societies, and they should get together with ICRP and say, we have to analyze the data in context, IQ and severe mental retardation, and look at the, for example, the causes of mental retardation can be manifold. Of course, the beautiful experiments of Rafi and all the others, which showed these developmental disturbances in the brain in certain stages, are beautiful. But on the other hand, we shouldn't forget that the maturation of the brain goes on. And we should also include those data of the radiation effects on maturation. And in this context, the data from the tinea capitis with a mean brain dose, also in this range of 100 milligray or so, and they showed at the age of 6 years, dramatic decrease in IQ. Mm-hmm. So the thing goes on. It's not just this week 8 to 15. The problem is between, say, maybe week 8 and 6 years or 8 years. It's a similar problem as with the cancer. Is the embryo as a fetus more sensitive to radiation-induced malignancy than the baby or the young child? We should not separate these too much, because people develop, and the body develops, and the organs develop, and the brain develops all the time. And just say it's only week 8 to 15 and the rest is irrelevant, I think is not true.
Yeah, sure. Klaus, I still have smaller question regarding spina bifida. I never observed this in animals. Is that normal? I
don't know. Why is it not? We see a lot of skeletal malformations are seen, but neurotube affects the exencephaly, for example. I think you showed one.
Yeah. I have many.
These are similar developmental things, but mice are different animals than humans.
Sure.
So we have to be careful, but the studies are wonderful for studying mechanisms potentially involved. But then the big problem is, how do you use these mechanisms in interpreting the developmental defects in patients?
Yeah.
It's a challenge for people like you and me, and has been for every day.
Yeah. It's really a pity that you cannot be with us, Klaus.
Yeah, I'm really sorry, but there may be an opportunity, and certainly with you.
Thank you.
Yes, thank you, Klaus. That was very good. It also reminds me, you talk about Leanne Russell and the early experiments. I think the recent, I'm sure you're aware of the relatively recent NCRP report on, and there's a lot of stuff from Bob Brent, early experiments from Bob Brent in there as well, which are very useful. I mean, you remind us rightly of these big experiments from decades ago, which are still of considerable value to us today. as you pointed out from the Russell experiments, and which we really do need to take account of. And I think that the NCRP report, I think is it 180? I'm just trying to recall, but it was 2012, I think, was the. No. Was it 180? Was it 180? Is it? Okay. Well, anyway, I'm sure you're aware of it, Klaus, but you know, again, it does emphasize from those, because Bob Brent obviously went back a long way, and that I found experiments in that report that I was unaware of, which were very useful. So I think you've done well to remind us about these early large experiments.
Yeah.
So thank you for that. Yeah. And your other thoughts, which are very provocative and right, I think. Anyone else want any final comments on that? Thank you again, Klaus, and I hope you're going to stay with us for
I will.
Yeah, our discussions today.
And I'm keen to ask some nasty questions again during the day.
No, I'd be disappointed if you didn't. I've known you long enough. Question one then is, do we have sufficient human epidemiological evidence of the existence of somatic cell effects following local external irradiation, local regional radionuclide accumulation, total body external irradiation, and whole body radionuclide accumulation? Okay. Well, the answer has to be no. in summary, but just because that actually flows into question two. What are the health effects after prenatal exposure? We've just been talking about some of this, follow-up information, outcomes, endpoints, which give them priority. So, I mean, what we do know, I think with some confidence, is that, as Klaus has just shown, that there are developmental effects as far as the central nervous system goes, which starts with these two sensitive periods that Klaus put up. Whether I mean, we have also some. I mean, still remains, and you can see this in the NCRP report that I was referring to, that still remains somewhat controversial as to cancer following exposure in utero, because there are some. Well, I was going to put up a slide that there are a number of aspects to this. I think you have the childhood cancer studies, and that is the biggest study, case control study of antenatal exposure and childhood cancer is the Oxford Survey of Childhood Cancers. But what I did over a number of years with John Bithell, who worked with the Oxford data for a number of years, was to do a meta-analysis of all the other studies that we could find in the world, and they are broadly compatible, the Oxford Survey and the other studies. But that only deals with childhood cancer, and I think that one of the major issues, if we just concentrate on cancer in childhood at the moment, is why it would appear from the case control studies of antenatal exposure, you get a range of childhood cancers, from childhood leukemia and the childhood solid cancers, with the possible exception of bone tumors, and it's about the only one that is not raised in the Oxford survey or indeed in the other combined studies. Whereas if you look at exposures after birth, then for sure, for childhood cancers, you get childhood leukemia. And childhood leukemia, of course, was one of the early signals from the bomb survivors, exposed after birth at a young age. But you don't see the childhood solid cancers. I mean, this is one of the puzzles and one of the controversial points from the medical exposure studies, the case control studies, is why you see this apparent difference between exposure in utero and in exposure just after birth. So why is that? And then, of course, you have the adult cancers, and really our only source of information on adult cancers following exposure in utero is the atomic bomb survivors who were exposed in utero. And this has been recently updated, Tsukiyama et al. Last year. And it does show that there is an excess of adult cancers in utero exposed survivors, but again a bit of a puzzle because the excess is in women but not in men. I don't know if you might like to talk something about that later on, Eric, but it's one of those it's one of those continuing puzzles that come out of the RERF data. Now, I mean, I think what I would say, just to preface that, is that, of course, as I recall, only about 15% of the survivors exposed in utero had died at the end of that follow-up. So there's still quite a lot of data to come. So in response to some of these questions here, it seems to me to be imperative that the bomb survivors who are exposed in utero, there is continued follow-up. Not just in utero, but of course those who are exposed at an early age after birth, because we're learning quite a lot about the continuing effects of radiation exposure many decades after the exposure. So I mean, I don't think, just from my point of view, it is essential that the bomb survivors exposed in utero are continue to be followed up, and that's a vital piece of information, I think, to see if there is this continuing pattern of an excess in women but not in men, which would, if it persists, it will be quite important. And we really don't have much in the way of additional information for adult cancers for those exposed in utero.
May I?
Yes, please, Klaus, come in.
This gender difference is fascinating story, but it is happens in all studies, not only Hiroshima. The most important one is in the childhood cancer studies. All childhood cancers show the same. And it's always due to two types of cancer: breast cancer and thyroid cancer. So the hormonal active, hormone-dependent cancers. And they occur early in life, and they are specific to women. And this is probably the main cause. There is one particularly important study which showed that the induction of breast cancer happens only after, say, the age of 9 or 10. no breast cancer is induced in the earlier stages in the childhood Hodgkin studies. It's a little known but very precise, very good study in Germany. And so I think age is after birth is a very important factor which may produce any funny data you want to see. So one really has to be extremely cautious with conclusions, in particular about male and female. Sorry.
Klaus, this is Kimberly. Can I ask you then about thyroid cancer in girls, because we see thyroid cancer younger than age 9. And but I think that may be due to the genetic predisposition syndromes.
I think the thyroid cancer, of course, we know it mostly from Chernobyl, and it's clear the maximum sensitivity to radioiodine-induced thyroid cancer is at the age of 3 years, due to different factors. One is the thyroid is still small, and therefore the dose for the same intake is higher. Second, that's the age where the thyroid is growing. So in adults, thyroid cancer is not such a big problem, but it is in children.
Oh, absolutely. Yeah, absolutely. And in fact, it's, it's something that it's one of my, as a bit of a tangent, the radiation protection policies I've argued need to be updated in this revision of the system, that we do not need to use thyroid shielding on our workers after age 35 in men and 40 in women. And we still use them throughout the life's career for workers, and that's not needed. But at any rate, but we do see thyroid cancer in younger age children. And I just wondered if it was from, only from cancer predisposition. So
I don't think so.
Okay, thanks.
It's Klaus. I'm just trying to think about the bomb survivors of radiation neutral. Because it was one of the questions I had about whether the excess of cancers in women was related to the sex-specific cancers, in particular breast cancer. And I don't. If I remember, I have to have a look. But if I remember, I don't think it was, because this was one of the obvious questions that occurred to me. And it's not. It's again, I'd have to go back and actually check the data, because it's about a year since I actually looked at it in any detail. But I don't think that there was this obvious signal of breast cancer or another sex-specific cancer. So it's a bit more complex than that. I think if I remember rightly. But thank you for raising that, because it's an interesting point.
I will look at the data as well. It's quite some time that I read it. Thank you.
Yeah, quite.
Thank you for reminding me.
But I mean, Eric, do you remember, Eric, offhand, or have you got a look? Yeah. Do you want to?
Yeah, I just pulled up, it's table 4 in the Sugiyama paper. There were 8 breast cancers and no obvious radiation signal there. And I think there were just a small number of thyroid cancers, just 1 thyroid cancer in women and none in men. So, but only 120 total cancers in women, 200 cancers in men. And it's a Japanese population, so you're seeing a lot of stomach cancers, a lot of liver cancers, and a lot of lung cancers.
Yeah.
This is mortality.
Yeah.
That's right. So nobody's dying
Okay.
of thyroid cancer. That's right.
No,
Yeah. Sorry. Yep.
And these days, in particular in young women, breast cancer is not as lethal as it used to be. So mortality data in this context are a big problem, because mortality of different cancers changed over the years so dramatically and differently for different cancers. So it's a huge challenge to interpret these data.
Yeah, absolutely right. And you know, one of the problems is that this is really the only source of information for adult cancers from exposure in utero, unlike the childhood cancers, of course. And the other thing that occurred to me, particularly with the bomb survivors irradiated in utero, is that there doesn't seem to be an obvious trimester effect, which I think on the face of it is quite surprising. You know, one of the issues that I raised early on yesterday, and I think it's quite important, is that when you're looking at in utero exposures, you're dealing with the early the early period when you know it's conceptus and embryo, ranging from a bunch of cells to essentially a baby, the late fetus. Would you expect the risk of cancer to be the same throughout the whole period of gestation? I would say a priori no.
Agreed.
And indeed in the Oxford survey, what apparently you see is that the risk of childhood cancer is higher in the first trimester than in the second and third, which again, I think a number of people, including Robin Moll, were quite skeptical of.
I know that.
Yes, I bet you do. But although it has to be said that over 90% of the exposures in the Oxford survey were in the third trimester for obstetric reasons, of course, and the number of exposures in the first trimester was relatively small, and those exposures were almost entirely for non-obstetric reasons in the early years of the study. So we could expect higher doses. So these data are very, very difficult to interpret. But that also in the atomic bomb survivor data for those exposed in utero, again, as I recall, and I'd have to go back and check it, but there was no obvious trimester effect in those data either, as far as the adult cancers were concerned, which again, to me, is quite interesting. Am I right, Eric? Is that how you recall? No, you've got to read it as well. And me, but that's my recollection. So again, in looking at our questions there, it seems to me that we have interrelated issues here. How does the risk, well, let's stick at for cancer for the time being, because I mean, obviously there are other effects, but we've got to, you know, these have different origins. But so let's just stick at cancer, because you know, that's a subject which has to concern us. But does the risk of cancer, both in childhood and adult life, how does that vary with gestational age? And indeed, how does exposure in utero, including of the late fetus, how does the exposure of the late fetus in terms of the risk of cancer differ from that of the infant and young child, if indeed it does. But on the face of it, from the Oxford survey data and indeed from the other antenatal studies, it looks as though you have a different spectrum of cancers, at least in childhood, than you do for exposure just after birth, which is quite puzzling. But it seems to me that is an issue still to be resolved, and it isn't something that is just confined to the Oxford survey data. So, Kimberly.
I was just trying to go back and look at, if I remember, and you remember this probably better, some of you, the other people in the room here, there was some animal evidence, mice, rat, that the third trimester had a higher, there was a suggestion that there was a higher cancer risk in the third trimester. Does that ring a bell? What? Mice? Yeah, it makes sense. So that's what I had in one of these slides. So that's why I want to keep that on the table. Do you want to comment on that? No. I mean, it's old data. And I think it's from the Unsker report. Uh, 1977, right? 1977. No, let's see. Yeah, but I mean, yeah. Yeah. To have kind of reports. They don't just pass
Right. So, and in that, I've just pulled it up here. I can give it to anybody if they want it. But there was no variation by trimester in those data. No variation by trimester. He said that, yeah. Variation in risk by trimester, no variation in ERR by trimester. So this, I think it said the same thing. Yep. Right. That Preston's paper is 2008. But they're not a whole lot of cases there. So you're not working with a lot of data, especially when you start to break it by trimester. You're really working with very little.
Yeah, I said that this is a bit difficult for me to believe just because the sensitive, and from a biological point of view, the sensitivity of the cells is quite like Klaus mentioned it also, is quite different from the second to third trimester. So this is actually not, yeah. I still have to look to maybe to the Preston paper, but see, I don't know which parameter or he took into account for this assessments or for these conclusions. So I am speaking just from biological point of view.
But it should be also dependent on the outcomes. Yes, because for this neuropathology, it was always for this neural tube, 8, 16 weeks, always sensible. It was always reported. But depending on which outcome you come, maybe, I don't know. trimesters will be.
Yeah, I mean, it is, as I was saying, a priori puzzling. I would have expected, if you'd asked me without any, you know, if you're moving from a ball of cells to a baby, is the risk of cancer in children and adults the same throughout the whole gestational period? I would have said, no, it can't be. and yet, there's apparently no trimester effect, except in the case control studies for, in the Oxford survey. The first trimester is higher, but there are a lot of, the data are few, and there are questions over it. So
I think it just back to the Oxford, all the third trimester X-ray exposures were for obstetric reasons to test whether rickets is present, which may cause trouble at birth. Practically, this was, of course, never done in the first trimester. This was indication, medical indication for the X-ray exposure, and there must be medical reasons why the woman was not absolutely healthy, whereas the third trimester were all healthy women. So I think the concomitant medical conditions were so different that one really can't compare.
yeah, I agree, and that was certainly Robin Moll's take on this issue.
I'm very sorry. I met Robin Moll in my not baby years. I'm in my mid 80s, so I have memories, and he certainly had a big influence on me. So if I say stupid things, maybe some may have come from Robin.
Well, he was pretty sharp, was Robin Moll, and he got most things right.
Maybe I learned something from him.
Yeah. I still.
He was my hero.
Yeah. I still read some of his papers now, and they have a lot. They have a lot to say. I mean, what is now up on the screen? It was just what I was looking for what I drafted out as as what the basis of what I might say tomorrow. But I'm hoping now that it gives us some guide as to our discussions. And I showed some of it. We've been talking about this, of course. You know, we've got conception right the way through, from conception to birth, 40 odd weeks for humans, but of course that varies from species. And as we've just said, it considers the conceptors right through to the late fetus. So that's a big jump. From a ball of cells to a baby, and that's what the challenge is. And again, as we've just been discussing, risks of cancer, the stochastic effects, and indeed hereditary effects, is likely to vary with gestational age, and for the teratogenic effects, for sure, as you've just addressed, Klaus, and I'd sort of stopped there yesterday, but I got onto your point that you've just been addressing about severe mental, severe mental retardation in the Japanese atomic bomb survivors irradiated in utero, and there's the plots that you indeed had shown as well. Severe mental retardation on the left, the plot on the left, but also the IQ score on the right, and this idea that there is although there is a threshold for severe mental retardation, if we go to IQ, then obviously less severe effects than severe mental retardation, but than the suggestion that there is no threshold for the mean, as Eric's pointed out, this was a mean IQ score here. So this is one issue that we do need to address in terms of do we really have a no threshold response for mean IQ there?
I think we have to go back to the original data.
Yeah, well, I'm not sure what the intention is at RARF at the moment. I know they're going back to some of the data to look at, see how the new dosimetry affects things. And in fact, I'll come on to that in a moment, just as I was going on to talk about the risk of cancer and hereditary disease, and the cancer risk. These, as we've been speaking of, the case control studies of childhood cancer and antenatal X-rays, and the cohort study of the bomb survivors irradiated in utero. The biggest study of the antenatal X-rays is the Oxford survey, as we've been saying, and this, I think, is interesting at what you can get from the Oxford survey. So the proportional increase in risk, the ERR, the excess relative risk, you get about a 50% proportional increase in risk, which is highly statistically significant at a 10 milligram X-ray. So you're down at pretty low doses here, and you're apparently seeing a reasonably strong signal, 50% increase, which is of concern to some people, that you get at these low doses. And of course, when we're dealing with antenatal X-rays, we are down at these low doses. One of the problems
do we know the doses? I think there's a lot of discussion.
You've just preempted exactly what I was going to say, Klaus.
Sorry.
Because, no, that's fine. That's fine. I'm glad we're as one on this. Because
I'm really following you with great interest, and just sometimes can't hold back. Sorry. Mm-hmm. Yeah.
Yeah, well, if you're gonna allow interruptions, I just wish you would put CAT scan instead of X-ray. 10 milligray is a CT scan, not an X-ray. Yeah.
We're talking about X-rays. So
1950.
if we're talking about, so in actual fact, that risk there of 0.5 at 10 milligram of X-rays actually comes from a national survey in Britain in 1958, the Adrian Committee survey, which came. So at that time, the average dose was around about 6 milligray from antenatal exposure. And of course, the Oxford survey went back into the early 50s and 1940s as well. So this 10 milligray here is just a reference point. But we are talking about doses in those days which were much higher than they are now from magnitude. But the actual doses that were received by the cases and controls in the Oxford survey, and indeed any other case control study, are very uncertain. So the confidence interval up there is only dealing with statistical uncertainties. It is not dealing, there's nothing wrapped in there from dosimetry uncertainties. And it strikes me that is a big issue. And coming back to Robin Mole Robin Moll was very critical of UNSCEAR. I think it was a 1972 report. UNSCEAR produced a set of fetal dose estimates from the literature, how the doses varied with year, coming down with calendar year. And Robin Moll said there was no basis in from the papers that they had cited for deriving those doses. And Robin Moll, being Robin Moll, was very outspoken on that issue and didn't mince his words. And indeed, when you go back to those references, it is actually difficult to find how UNSCEAR actually derive those doses. So, in essence, there is a big question over the doses that go into this particular risk estimate. But there is little doubt that there is a raised risk. The problem actually comes is actually assigning the doses to that risk. And one, I alluded to this. What this shows is from the Oxford survey, which is the red dots going across here, and all the other case control studies combined. This is what I did with John Bithell, and we eventually published actually after John Bithel's death. And what it shows is the relative risk of the various types of childhood cancer running along here for the Oxford survey and all the meta-analysis of all the other case control studies across the world that we could find, because there was a continuing question of why in the Oxford survey, if you just look at the red markers across here, why is it that all these childhood cancers, with the exception of bone tumors, are showing a more or less the same risk as each other as you run across here, which is most unusual. It's not what you would expect, again, a priori. If you look at exposures after birth, it's certainly not what you see. I mean, you see here, here's leukemia, and here's lymphoma, bearing in mind that this is childhood cancers. But when you look at all the other studies other than the Oxford survey, then you see the same pattern, more or less. You run out of statistical power at some of these rarer tumors, but the consistency of the bone tumors not showing anything again. So it's not something that is specific to the Oxford survey. It's something that you see across the other studies as well, which leaves you still with this puzzle. Why do you see a relatively uniform raised risk in relation to antenatal exposure across all these different childhood cancer types, with the exception of bone tumors, which is not a typical childhood cancer? And in particular, the embryonal tumors, the neuroblastomas, Wilms tumors, for example, you're still seeing, and bearing in mind that these are risks that are produced predominantly by exposure in the third trimester, and indeed in the last month of pregnancy for obstetric reasons. How is it that you're seeing this relatively uniform pattern of risk of childhood cancers? Not what you would expect. And indeed, if you look at the pattern you would get from exposure just after birth, infant and young child, well, it's dominated by leukemia and not much else until you get into adult life. So you're immediately presented with with a puzzle here, and certainly I would say that was one of the major issues. If you do accept that there is a risk of cancer, childhood cancer in this instance, from these low doses of the order of 10 milligram of X-rays, why is it producing this pattern of risk, and why is this apparently so different from the pattern you get after birth? If anyone if anyone has an answer, please tell me. Anyway, I just put that up as one of the as to illustrate what I regard as one of the big issues, at least as far as cancer is concerned. And this is just reflecting what we were talking about early on. These are the bomb survivors who are exposed in utero, and this is the recent study Sugiyama et al. Published last year, when we were saying that here you see this raised risk of adult cancers in females, significantly raised risk, but not in males, which is puzzling. But again, as we've just discussed, small number of deaths. We're only looking at the survivors at the end of follow-up here, who were in their mid-60s, so they've still got some way to go. And again, I think it's very important that is continued to be followed. One of the puzzles that there has always been is that if you just look at childhood cancers, of course these are dealing with adult cancers. If you look at childhood cancers in the bomb survivors exposed in utero.
Sorry, I mean, I don't want to just interrupt you, but it seems that we don't see actually. At least I guess from your gesture that you move and you show something on the screen.
Yeah, I'm sorry. Yes, of course, I'm using a pointer here, but I'm hoping you can. you see this? You see the slide, right?
No.
No.
Oh, I do beg your pardon. Oh, right. I'm sorry. You should have shouted earlier. I don't.
Anyway, I listened to that carefully, but I tried to follow you without figures.
Very sorry. We thought that you were. We thought you were seeing.
Mm-hmm. But let's please continue as you are, because I mean,
we're just trying to sort this out here now. That we don't quite understand why. Can you see this now? Can you see slides now?
I see this.
Yeah.
Yes.
Oh, you see it.
Yeah.
Okay, you see it now.
Yeah.
Yes.
Okay. Okay. Gosh, you should have shouted before, because we've been looking at these slides. So, let me just. Oh, now I can't move it. Right. So that's what I was showing before. This is. Can you see that?
Yeah.
Yeah. Okay. Did you see? You didn't see this before.
No.
Okay. That was just showing the variation of relative risk from both the Oxford survey and the other cancers, the other case control studies combined across the various childhood cancers, and showing that you had a relatively uniform, both in the Oxford survey and the other studies, raised relative risk with the exception of bone tumors, which is the puzzle that I was alluding to as to why exposure predominantly in the third trimester, last month of pregnancy usually, produces this pattern of risk, which is across uniform, relatively uniform across the typical cancers of childhood, with the exception of bone tumors, but probably not typical childhood cancer. whereas you see a different pattern for exposure after birth. So my apologies for that you didn't see that before. And it was just coming on our discussion about you see the excess in adult cancers and the bomb survivors exposed in utero in females, but not in males, but just this relatively small number of deaths, only 15%, as I recall, had actually died by the end of follow-up at the end of 2012 for this study, but something that needs to be resolved. And when you look at the childhood cancers, so the cancers in childhood amongst the bomb survivors who had been exposed in utero, to make the comparison with the antenatal X-ray studies, well, of course, we're dealing here with doses. Average dose to the bomb survivors exposed in utero about a quarter of a gray, which is considerably greater, of course, than what was received during an antenatal X-ray examination. But there were 2 cases of childhood cancer against about a half expected, which is not big numbers, but at least there's an excess. But the puzzle has always been why there is this absence of childhood leukemia in the bomb survivors irradiated in utero, although the number of cases expected is quite low, as you'll see there. But given the pronounced excess risk of leukemia in those exposed at a young age after birth, this is quite surprising. But what I think is one of the most surprising findings is this, which is Nori Nakamura's group, which is looking at stable chromosome translocation frequencies among those who were exposed in utero. And you can see that there's the maternal uterine dose going along the bottom, and then there's translocation frequency. And the puzzle is that once you get up to these moderate and higher doses, you see some sort of signal at the lower doses down here, but then it goes flat. There was also some data from only 13 exposed mothers, but the translocation frequency in the mothers follows what you might expect from laboratory data. So a steady upward increase in translocation frequencies in the mothers, which is not replicated amongst the survivors who are exposed in utero, quite flat beyond 100 or so milligray. And why is this? And I should just point out that this has recently been confirmed by John Cologne and his colleagues from the RARF using the latest set of doses, the DS02R1 doses. So a much more sophisticated statistical analysis was carried out by John Cologne et al., but essentially arriving at the same conclusions that that you have the translocation frequency is pretty flat at moderate to high doses. Now, it seems to me that that's saying something pretty important about the response of the hematopoietic system to exposure in utero. That perhaps damaged cells are more easily killed in utero, and what you get is an undamaged stem cells coming in to repopulate the bone marrow. But this does seem to be a real effect, which is what Cologne et al. have shown. With the newer doses, it has to be said that these are these are still uterine doses rather than fetal doses, and which obviously introduces an error for the late fetus. But even so, it's very difficult to see how that can be, that pattern can be produced by these dissymmetry uncertainties. And maybe that this is something of the basis of the absence of childhood leukemia. Obviously, these are translocation frequencies in peripheral blood lymphocytes. So the two are going to be related. It again does seem to me to be an important issue that requires resolution there. And Nori Nakamura's group has repeated this in experimental mice and found the same thing for the hematopoietic system, but not, as I recall, and I'd have to look up again, but not for breast and thyroid, where you get a response which is more or less as you would expect. So again, I would say that is an issue which we need to address. So I mean, I just put those up as a means of concentrating our minds for the questions. Yeah.
Well, I wanted to go back and comment on your question for the audience, which is, why might there be, a higher risk of cancer in the fetus, especially third trimester versus children? And, one of my thoughts, and I want to ask everyone, is, I'm sure you've discussed this many times with people, Richard, that, in fetal life, there are different cells that are present that are growing very quickly. And these are the not only stem cells, but the blastoma cells, right? And the types of tumors that children have, especially young children, are very different, the type of cancers, than adults or older children. So these solid tumors that you're looking at are they're omas, they're blastomas, they're hepatoblastomas and nephroblastomas, and those are the things that grow very quickly. And once they form in there, they're leftover cells that are from the fetus, and they normally, in almost in normal children, they regress. And the neuroblastomas are really bad actors. They kill children still. We still haven't figured out how to treat children, and very few survive. But in some of these other cancers, we have very good chemotherapy agents for the kidney version of the blastoma. So what I'm trying to say is that has that been a consideration that for some reason, if you radiate those sorts of cells in that third trimester or maybe even second trimester, that has a very different response than after they're born, when those cells have regressed almost entirely. Not always, but almost entirely. At birth, there are still some immature, for example, red blood cells and other cells. So.
Yes, for sure. And one of the, I mean, John Boyce, for example, and Bob Miller were certainly onto that point and saying, well, why are these embryonal tumors showing a response to radiation in the third trimester, and apparently showing the same response. The Wilms tumors, the neuroblastomas, for example, apparently showing the same response as leukemia, lymphoma, and it's certainly a puzzle, but that's that's what the data say, and that's why I sort of throw that in as one of the what I think is a basic question to be answered. How does that pattern get produced across all those different cancer types, and why is it so different from postnatal exposure?
But I mean, I'm giving you a hypothesis. And I'm just wondering if anybody in, in genetics has looked at it, or if we could find somebody.
When are we supposed to go for coffee? Oh, okay. Okay. The only thing I would say in response to that, there are also, this is a translocations in the bomb survivors arrayed in utero. There are also, as I recall, there was no trimester effect here either, despite the evolution of the blood forming of the mitopoietic system throughout the gestational period. Yet another puzzle. We're going off. We're having a coffee break now. About half an hour, is it? Half an hour. So we see you online people at 11 o'clock here, wherever you might be.
Okay, we're back, everybody, from a nice coffee break, and I think we were talking about some of the first questions. I'm not sure we got through all the questions. Did anybody on the web want to comment on the questions? Can you see them? We've got that first question. Can you see the questions? I think we saw some people were there on the. Yeah, great. Ahmed, thank you. All right.
Can I add one comment short?
Great. You can see that. Okay. So we, I think on the right-hand side, there are some questions that we may not have talked about, which are about clinical and lifestyle information that may be important to address that may be confounding. I guess we started to talk about that. Any comments about it? All right. Yes. Yes. Yes.
Yeah, yesterday, Dr. Sakata talked about the A-bomb survivors and one of the limitations of that study is trying to tease out the difference between lifestyle information or socioeconomic status or conditions after the bombing from the effects of the bombs, the radiation itself. And it's an important limitation, and it's somewhat to do with this lifestyle information or SES. But I looked up the Kato reference that was referenced in that paper, saying that the A-bomb survivors had a lower socioeconomic status than non-A-bomb survivors. And there were three groups in that paper. There was within 2,000 meters, beyond 2,500 meters, and then non-A-bomb survivors, so some sort of outside control group. And it's true that the outside control group did better than the A-bomb survivors in terms of lifestyle data. But what you're really interested, that's not surprising. What you're really interested in is trying to compare the people that were proximal to the people that were distal, but all in city. And likely their socioeconomic status was quite similar. If you're close to the bomb, does it make much difference if you're 2,000 meters or 2,500 meters away? But dose drops every 600 meters, drops by half. So to me, those data are actually quite good. I guess my concern was that, wow, that's a big problem. But the more I thought about that particular concern that came up yesterday, I guess I wasn't as concerned about it after I thought about it a little bit. So I just wanted to mention that when we start talking about lifestyle information, when we talk about the A-bomb survivors, I think it's a bit more of a uniform distribution in terms of socioeconomic status than that Cato paper suggested. I guess that's what I want to say. Thanks.
Thank you. Other comments?
Yeah,
Oh,
may I, sorry,
Yes.
may I comment on that? Lifestyle is certainly important, but particularly in Hiroshima and Nagasaki, these people had radiation exposure, yes, but their main exposure was the flash burns and the all sorts of severe illnesses, which were the direct consequences of the bombing. And this, of course, was very closely related to the dose. So you have a confounder which is extremely strong, that is medical condition in the first 3 months after exposure. And this certainly must have had an influence on in utero development. And I think it's quite obvious that the number of pregnancies in the various stages were very different. And this is probably due also to death of the mother. So there are problems. Maybe some mothers survived after severe illness. So these data are not closely related in the RERF communication. And I think it's something which should be, particularly for the in utero data, we must have information on that. Otherwise, we would just concentrate on those, which of course is a matter of distance, but one of the major factors would be completely forgotten.
Eric, I think you're the only one. I can't address that, or I don't know that we can get that. Yeah. Oh.
Omid?
Sorry, I wanted to come back to the last comment from the last session about the different signature between the utero biosystem and mother. I don't want to mix the topics for non-cancer and cancer, but just I give one example that this hypothesis can be very right. I think Rafi remember that when we did the first in utero heart proteome, actually the life was very difficult, because the first time we faced as a profile of the heart that it, at least I didn't see in many of the heart proteomics that I did for adult mice. It's not only the difference in magnitude, it was not a smaller changes, it was sometimes as a mirror changes. For example, what we know from the heart effect most of the time metabolism goes down and mitochondria protein goes down, and then we have a switch of the machinery of the energy metabolic activity. But in utero, I think in Rafi they would E11, if I'm not wrong, it was completely different. I mean, we have upregulation of mitochondria. It's clearly that there is a certain, as a given number of the genes and proteins that will be heated, and they are not exactly doing the same, they don't have same characteristic in the adult. If it's true in a cancer issue, is a matter of debate, but because it's a different issue. But I think it's important to consider it.
Yeah, when I see now the discussion how it is going, let's say it's clear that there is a difference between cancer, let's say, following exposure in utero, and maybe somatic changes. Maybe there should be an effect on, I would say, some kind of stem cells effect that we didn't discuss so far. And this is, I think, something that can explain later on induction of cancer. If it, and there, maybe I can now agree that there is no trimester difference. If it is stem cells, then it doesn't matter when the exposure occur. With somatic, I think the question is totally different. There, it depends on the development stage and when the exposure happened. Can we make this distinction?
Yeah, it's a really good question. I know that there's a lot of research on the environment of the different cells, and that's not my area of research. So if any, I don't have any comment on that, but it did remind me that there's another aspect of that we haven't discussed, which is that third trimester effect of well, second and third, that you know, these babies show smaller size, so microcephaly and smaller size, and we didn't talk about smaller size. And that's something that the Sugiyama paper and the marine hatch paper from the Chernobyl babies showed that we should also mention. You know, they have overall smaller size, and that continues in the Sugiyama or in the other papers from the RERF data into the adolescence, and I can't remember the paper, but in the adolescent height, they're not as tall. And I know that in that adolescent paper, they also had hypertension, these in utero cohort. And I don't know if that continued into adulthood. I mean, it's just curious that, and to me, it makes sense. If you radiate the babies, you can affect their vascularity, and you know, just like you're affecting their height, you're affecting everything. It's an, you know, it's a total body dose. And the other thing that I wanted to mention was that the Chernobyl babies, you know, had the smaller size. They had the smaller head size and the smaller chest size, which the RERF had the RERF cohort also had, but the Chernobyl babies also had, or the in utero cohort had longer gestational ages on average, which was related, which had a dose dependent effect. And I thought that was a really interesting thing. And I wondered, although I haven't been able to find this out, if this was related to, this was just published last year, if this was related to the you know, a thyroid effect, you know, a thyroid hormone effect from the iodine, radioactive iodine. So I don't know if anyone has any data on that, because you know, it crosses the placenta and can certainly affect the fetal thyroid.
I can just maybe suggest if you agree, maybe if you pass me your mails and I create maybe on like Drive Excel, and we can put interesting papers that you already know. No, just starting what we will include in our review, no? I mean, further, but I mean, we can keep it, no?
Yeah, I think we have a Google Drive already from our task group, right? Oh, OneDrive. Yeah, and we can share that with you. Yeah, right, right, right. Good point. All right. Yeah, let me see. Yeah, that's a good point. Okay, thanks. Yeah, you're okay. Well, why don't we go on to the next question, which is what biological samples might be informative to link with the epidemiologic studies we have. I mean, we want yeah, blood. Yeah. Yeah. Okay. Blood, saliva. You writing this down? Yeah, we want tissue samples. I mean, MIAC, they have a lot, right? But that's yeah. Unexamined in some cases. Yeah. It's okay. Urine. Yeah, you said that. Okay.
So, about biological samples, usually they are not used in epidemiological studies. They are collected, they are collected in epidemiological studies to be used for molecular epidemiology, if you like, or it depends. So you're talking about de novo collection. De novo collection, or because informative, I mean, is or in the context of radiation, ionizing radiation, and biological effects of radiation. Well, I mean, yeah, of course, often we talk about target tissue, you know, if you're interested in cancer, different sites, you know, leukemia and so on, or you're talking about surrogate tissue that may be used as a marker of exposure or marker of risk. So all kind of, I guess, there is increasing evidence, and I mean, I showed some yesterday that you can use surrogate tissue like blood, whole blood, you know, even blood spots, something that perhaps was not mentioned. And as you know, that the blood spots are so-called Guthrie cards are collected in the context of national screening programs for different syndromes. So they are stored, and often, you know, even stored room temperature or refrigerated somehow. But you can extract from this. These are really gold mine, because to use where DNA is used, you know, because the DNA is pretty stable. We showed that, for example.
It sounds interesting, but I can't hear. Please go closer to the
Yes.
mic.
Okay.
Thank you. That was.
Yeah. So I was just mentioning the cord blood and blood spots. So these are the blood actually dropped on the filter paper and then stored. And this is collected as a part of national screening programs for different syndromes. And and you can actually connect this to the registry. And from these blood spots or so-called Gertrude cards, you can actually extract DNA. This is compatible with profiling methylome, for example, of course, or genetics and so on. So we have, recently published a couple of papers where we show that you can use this, even small punch from this blood spot, you can do methylome whole genome-wide methylome profiling and so on. So there's a lot of interest in this, for example. Yeah. So of course, all other,
I strongly support this. I've done exactly this when I was in the Marshall Islands. The only thing which one really could export into the United States anyhow, and just store and do fantastic analysis is blood drops. You don't need liquid blood. These drops on paper are fantastic. So fully support your suggestion.
Omid?
I mean, consider that you are in the position to answer this question or to address this issue in a text that you want to prepare. But before writing that, certainly you make a short introduction. Then this introduction would be actually the answer to the question from Rafi from yesterday. What is the application of biology as a vet lab in this context? If we know that, then we know that which sample we should collect or which sample is collected can be applied. As how biology can, as a biological data can be used in the context that we want to address. This is very important, at least for me to understand it.
Can I take it that you might be willing to help write that introduction, Ahmed?
It is anyway attractive. I'm sure that if I have opportunity, I would appreciate it. But if you think that I can help, I would help. But let's start to address the issue. Surely, I would be.
Yeah. One of the things I think we should do tomorrow is try to meet up with some of the other groups to narrow our discussion down to what we want to cover, including what you just said about question 5.
Next question. What dosimetric assessments are likely to be informative in epidemiological studies? Medical imaging of pregnant women. This is for you. You have to answer. Medical imaging of pregnant women, radiotherapies of pregnant women, OSCC, RF dosimetry in OAT studies. Yeah, exactly. So it's when you think about nuclear medicine, you have the records of the activities that are injected to the patient so that you can track. Also, in the anamnesis, you have the physical characteristics of the patient, so it helps us to calculate the doses. In epidemiological studies, in cases of internal dosimetry, then we need to know the whole body counting. So what was the whole body counting, or a school counting, or thyroid counting? What else?
May I comment? For epidemiological studies, for imaging procedures done, we certainly don't need any whole body, also not for, because the damage occurs in specific tissues. We need the doses in specific tissues, sometimes even the dose distribution in the tissues. And for medical imaging, we need, if at all possible, the images. In the good old days, we had these enormously pack of a film which from which the physicists could calculate those distributions. Today, we have digital images, and they can provide those distributions. Even say if a pregnant woman receives an exposure somewhere in the upper abdomen, the dose distribution within the fetus is enormously different. The head is in the pelvis, but the the gonads, the developing gonads, are very close, say, to the stomach. Depending on what we want to study, we need different. We need to need different information, and therefore we need the full dose distribution in the critical organs. And
I
this
agree.
is possible with modern medical imaging procedures, and the data can be stored, I don't know, probably for 10, 20, 30 years, but that's already something. For radiotherapy, I think the treatment plan should be able to calculate it there, but unfortunately, the modern calculation procedures only go down to about, say, 1 or 2% of the prescribed dose, and that's certainly not sufficient. If you give 60 gray, and in the end you just can calculate down to 1 gray, we need lower doses, and therefore we have to talk to the radiotherapy societies. What can they do to get to store those doses? In particular, and we've discussed the most common situation, that's pregnant women. But even there, it depends very much on which stage of pregnancy. Oxford childhood cancer studies, they tried to measure the dose in the baby using the old equipment. But of course, the dose is enormously different depending on which stage. If it's in, say, week 30, then of course you have a total body dose which is much higher than in the same situation if you have a just week 3, 4, 5 pregnancy. So it really depends on what you want to know, and if you don't know which is the effect which you want to study, you have to be able to store data in such a way that you can calculate back. You need then also specific algorithms for the different endpoints. This is something which needs to be considered by the medical physics community. How can we do it? Dosimetry in old studies is, since we want to look at long-term outcome, we have to look at people who've been exposed 10, 20, 30 years ago.
Yeah,
this is a major
I agree,
issue.
Klaus. I agree, Klaus. I think this Kimberly, I think that's a question we're asking. And I think the answer is yes and yes. And I think now in most of through the BSS and with digital imaging, we're required to record absorbed doses or a nuclear medicine administered activity ideally per weight. So we have a way of tracking doses even in accidentally exposed pregnant women, which happens every day. often for trauma, most commonly. And the for radiotherapy, I think I said, it's 1 in 1,000 women will have to have radio or have cancer, and some of them at least will need radiotherapy. We have a task group in the ICRP 116, which is looking at guidance and pushing for guidance to track the imaging and pushing the radiotherapy societies, ESTRO, ASTRO, and the others to do the same thing, track the imaging doses, the cone beam CT, the fluoroscopy related to the radiotherapies, because they don't right now, and they should. And they're not optimized. So we've published a paper on the current variation in imaging that they do, sometimes 4 cone beam CTs every time they do a therapy. So it's pretty extraordinary. And this is not, on a pregnant patient necessarily, but just to give you an idea of what they're doing. So we're trying to push for registries for children. And right now there is a proton therapy registry for children pushed through by the NCI in the US, and it's international. So we hope we would hope that there could be more such registries, and I think that's an answer. It's because it will combine dosimetry with clinical data.
Loud. Yeah. So about these registers and doses, we also were discussing in Spain about it because it depends on countries. If you have state hospital, for example, yeah, you're recording. But if you're going to private, in some countries they are lost. So, for example, in Catalonia, we were speaking about, it was a project to create kind of dosimetric passports. So where all doses from all clinics, private, states, and actually from dentists, because we have dentists separately, nobody is recording there anything, to have for each person to have in one place. So this project is not realized, but it was a good idea maybe, and it would be good to track everything, because sometimes even we had cases when one woman, for example, mother, didn't like a picture received TC scan from her child. In the same day, she took her child in another private clinic, and the same day she repeated just to confirm her, because she was not aware about those. So this happened in all other cases when people are performing errors. Sometimes maybe one leg is exposed, maybe left leg, but should be right leg, and also repeating, medical errors, and etc. But all these tracks are lost also.
Maybe coming back to the radiotherapy, there are certainly a big problem in some specific patients from the imaging done sometimes every day. If you have high precision treatment planning, then you need images very often. However, also the dose from the actual treatment beam can be a problem. And I'm particularly concerned about the hype of proton therapy. And shouldn't forget that protons interacting with matter produce neutrons. And I think not enough has been done to consider this in the situation of pregnancies. We certainly don't want to expose embryos or fetuses to neutrons, because we have no idea what would happen there.
Right. Okay. Good point. So, I push for, these registries and so that we can follow them. 7, I think, question 7, I think we covered. Are there periods of sensitivity in the embryo or fetus, windows for threshold? So we'll go on to question 8. Is there new information or improved knowledge on tissue reactions since 2007? I think Richard also kind of covered this in mentioning it yesterday. Do you want to say anything about that? Yeah, let's go to the next set. Great. Okay.
May I just to tissue reactions? I had a long discussion with the chairman of Committee 1 of ICRP, and he told me that ICRP is very unhappy about the whole concept of tissue reactions, and they want to have a thorough discussion on that. So obviously it's something going on at the higher level of ICRP. And as you may imagine, I'm very happy about this move.
Yes, I know, Klaus, I'm on the main commission and I talk with Dominique about it frequently. All right, question 9.
Yeah, maybe for question 9, this is also to answer to my question and maybe the Omid questioning. And I think there are a lot of in vitro, in vivo, ex vivo experiments that can be, let's say, analyzed, reanalyzed, and try to show up, let's say, more about the study of radiation-induced effects. I have to indicate there, although many studies have been performed on cell lines or on animals, recently there is this organoid that's more and more used that can, let's say, simulate a human tissue, and there can be give more, let's say, effective explanation to what happened in a human. For the brain or for other tissue type cells. So this is, I think, is promising in terms of mechanistic studies and studying the effects of radiation for human, because it's always difficult to translate the data from animals to human situations. And I hope with these organoids, I think we can go a step further.
May I just add again, I'm sorry that I talk too much, but that's my matter, my way. The first thing my students here the master course learn, the model which depends on the question, and how cannot answer this. Those exposures of embryo and fetus have to be studied in the embryo or fetus. And
Klaus, we cannot hear you. You're muted. Yeah. You're muted.
I'm no longer muted, but I've obviously had a problem with the internet connection. The computer just told me about that. Do you hear me now?
Yes, we hear you.
So the most important answer for that is the model, the suitability of a model depends on the question you ask. In vitro models are only able to give you information on mechanisms, but not on damage and tissue effects, because tissues are organized structures which you can't fully model in vitro. Ex vivo is usually very good, and in vivo, it depends on whether you have a suitable in vivo model, and that would be question 10.
And well, I'm speaking Ludmila. So I'm referring to this experimental designs, but also you have natural experimental designs. So we use cohorts and you know, ecological studies. I mean, these studies also have weaknesses because you don't reproduce environment very well, no? As a factor influence that in real life we don't have here. It's like just pure doses and that's all. It's not also reality. So.
I fully agree. This is indeed my worry when we are working in mice, for example. So we have the perfect conditions. They are in the good temperature, good conditions, good food, good water, good whatever. It's the ideal word. So, and this is indeed is totally different from real life, where people sometimes with different lifestyles, with different, let's say, capacities or different illnesses. So it's totally different indeed from real life. I agree.
But once you are considering animals, you have a lot of uncertainties aside from this completely stable and previsible environment. You have a lot of uncertainties concerning that. So you're using animals, taking it, and then you translate it to humans. So it's not just the environment that is an uncertainty.
Maybe for this question 10, where we are, there is one thing one really has to consider. There's practically always a reason for radiation exposure. People are sick, they are treated with radiation, they are diagnosed with radiation, and then they are treated for whatever they have with all sorts of drugs which are with unknown long-term effects. So one has to be aware of, at least, of this problem, that quite a bit of what could be considered a consequence of radiation exposure could be a consequence of medical treatment which heals the patient. And this is probably never properly taken into account of, because it's maybe impossible, but it has to be considered.
Omid?
I have two comments on this experimental design. I think if you have a chance, I'm sure that you have often in your career to work with the cohort. I say it honestly because I could work with the Mayax heart, for example, as one of the unique samples available at all, heart autopsies. It is not life so easy that we consider. Okay, it's a very complex system, and we are happy that we have a real sample. But now, when you start to have access, you have a difficulty to get samples, to have a difficulty to arrange the samples based on the comparative biology concept. For example, they should be comparable at all. They should be same age, same gender, and then you go narrow down, and suddenly you lose again your selected cohort. And why I want to say that, I think if we want to work later in very near future, I hope that on cohort, they should be better organized. They should be accessible for all people. As a scientist want to work on, it should follow all the data documentation. It should be fair, as an abbreviation documentation. And I hope that in the next level of the European or international organization, we address the issues of accessibility of the course. The second problem is when we completely move from the one artificial condition, which is an animal study, to the cohort study, we should not expect that, okay, we cover everything. Just as an example, is the Richard just showed the one example from the translocation, is from 2022, and you see that they didn't have access to many co-founders. They try to only include the smoking, and then at the end they excluded because it's not addressed the issue they wanted. It's very optimal, but it's, believe me, it's very challenging to work with the samples, especially if you're talking about the tissue. I state that the in vitro and cohort study can be complementary.
Yep. So yeah, for the same, I mean, on the same topic, we all agree, I guess, that in vivo models are more informative, but as you know, there is more and more ethical issues and pressure to reduce using animals and so on. But what is in the modern biology now kind of increasing trend is to use the organoids and also wherever possible using single cell analysis, because they are also more because of the heterogeneity, tissue heterogeneity and so on. And there is now technology is compatible with using single cells. Well, it is becoming more affordable in terms of cost and so on. So, but the so one important consideration is if we study the transgenerational effect. I think then it's important whether we expose the mother or father or both, or which stage and so on, and how far you follow the offspring. I think that's important because if you want to see whether this is simply intergenerational, as we discussed yesterday, or this is really like so-called, bona fide transgenerational. Anyway, yeah.
All right, I just want to go back to something I think we were saying about the other effects. I think, Klaus, you were saying something that we don't know if it's a radiation effect in the fetal exposure or something else that happened after that, that some other environmental effect. And absolutely, that's true. We have some information about mice research that I know was done to look at radiation and potentiating effects of some chemicals. And this was from Unscared, that chemicals like tetracycline and iodoacetamide were potentiating, or they were radiosensitizing chemicals. So those, we don't know what they do in humans. We can say they're probably bad actors. But we do have animal models that looked at those, at certain chemicals. Yeah, and other exposures. Yeah.
Just wanted to make a kind of small hint, because we are implementing, don't be offended, because we are implementing gender, but actually when we are speaking about biological studies, it's better to use sex, because for biological, gender is pure social concept. So it's for psychological studies, yes, but for here, well, don't confuse.
Next question. Where are we? Transferability of animal data to humans. Yeah, that's yeah. We keep talking about that in every question. Any other comments about it? How about we go to 12? Which endpoints, and we've also talked about this, which endpoints and our surrogate markers are likely to be the most informative? And we've touched on this, that we, are coming. I think these are newer tools, like we talked about blood spot, we talked about organoids. Yes.
can give just example because I've been working for like 2 months ago in assessment of a new technology which will be used in medicine for cancer detection. And actually this new technology which can allow to detect cancers like 4 years or even earlier for 50 types of cancers. They're using demilitarizations of blood sample. So this demilitarization that you are like soon it like one of the most the most important, I think.
Yeah, company. Yeah. So well, but yeah, this is more kind of really early diagnosis for early diagnosis. Yeah. So the idea is to have a kind of set of the so-called informative driver genes.
Please let me hear you.
Yeah, so I think the Grail, this is a kind of spin-off of this that invested a lot into the circulating DNA, tumor cell-free DNA, and that can be actually the technology now allows to profile this tiny amount of DNA and look for mutations that can detect a spectrum of cancers. So this is now some really promising, but and of course company communicate, you know, very positively the encouraging results. But the idea is to have a relatively powerful technique for early diagnosis using the blood and for different cancers that are, you know. Yeah. So the tumors. Yeah. Yeah.
Actually,
could be methylation, could be mutations, could be others, you know, and so on. But this is very promising. Obviously, I you know, I would, you know, also.
It is particularly.
Go ahead, please.
It is particularly promising for detecting early recurrence in some tumors. We are doing this in glioblastoma in Munich at the moment, and the primary treatment is clear what to do, but you have to try to find out when the tumor comes back. And if you can detect it early, you have a much better chance of doing some good for the patient. And I think this is one of the really important features of research in all sorts of environmental damage and cure cancer. And I think it could be used also in some studies in humans exposed to all sorts of toxic agents and certainly also radiation. I fully agree.
Yep. Yeah. Recurrence is a problem, obviously, even if you have very efficient drugs. But actually what they talk about here and also the early detection. So it's really like looking the months or years before cancer really, there is diagnostic, you know, manifestation. Yeah. So I think that's very promising to detect early before, you know, primary cancers. But of course, recurrence is also, this approach can be applied for the recurrence, which is a problem for many cancers, obviously.
Question. Duration of follow-up, newborns, adolescents, adults, old age.
Yeah, I think we know now that there's evidence of fetal, the fetal environment affects all life into old age. So I think we need to say that. What?
Okay. What is the relevance of this question now? Yeah. For previous studies, it's fine. But for future studies, is it still relevant? We know less and less pregnant women are exposed. So there will be almost no in utero exposures.
Hopefully.
Well, it depends on where you live. If you live where I live, that's not true. No, because if you have trauma, motor vehicle trauma, you're going to get a CT. And if you're bleeding in your pelvis, which is a very common place to bleed from trauma in your abdomen or pelvis, and you're pregnant, you're going to need embolization. And you will often, you'll have a CT, often two-phase, and then you're going to need embolization. So you're going to go up to 50 milligray. So
Yes, I mean, it is clear that some pregnant women are going to continue to be exposed for a variety of reasons. But I mean, I think again, this 14 emphasized the point. For example, the importance of continuing to follow the bomb survivors who are irradiated in utero, or indeed in early postnatal life. I mean, I can imagine that there might be pressure to say, well, we know everything. We know we can know from the bomb survivors, but I mean, because it costs money to continue to do this, but it is important to continue to follow these. It's clearly so. I mean, if there's only 15% of the in utero exposed survivors who have actually died at the last follow-up, there's a lot to learn there. So I'm not quite sure what this particular question was aimed towards, but obviously you do, because you're ignorant of how long these effects will last in life. It's important to continue to continue follow up and resist any financial or political pressures that might be there. So I think it is quite important to make that point. Did we address question 13, or it was sort of wrapped in with everything else, wasn't it? Okay, all right. Yeah.
So, sorry. Yeah, there's strong support, at least to date, to continue the A-bomb survivor studies with the children and the in utero exposed. So I think those studies will continue. But this question 14 is tricky. It depends a lot on your study design, because it's expensive to do long-term prospective cohort studies. And so if you're going to have only X number of dollars to spend, what's your best bang for the buck? And you're not going to see, I mean, we don't see much in terms of adolescent cancers from A-bomb, from exposures, at least in the A-bomb studies. And it doesn't seem to be a lot of support in younger life for these cancers occurring. So it may not be that cost beneficial to do long-term studies from immediately after birth. It might be something that starts quite a bit later. Maybe screening, blood screening, or fish aberrations or something along these lines might be good after or younger time in life. But to do long-term prospective cohort studies just on everybody that's exposed as in utero is not feasible.
And yeah, this is indeed a problem of costs. So, and yeah, I feel sorry, for example, for the Chernobyl data that we couldn't use as much as we can, like the atomic bomb survivors. And there, maybe the question of costs should be discussed, because let's say, how can we manage this long-term, let's say, follow-up?
I think what
another-
do we want to, why do we need these data? Certainly the gold standard is the lifespan study and all associated studies in in RERF, and we all are absolutely convinced that this has to go on until maybe the next generation has died. But and then there are a few which are obviously well established, like the MAYAC, the TETRA, and some of the liquidator studies. But I think that's enough, except for the radiotherapy. And fortunately, in some countries, it's now being clear that a cancer survivor who has been treated with chemotherapy or radiotherapy is at an increased risk of long-term damage, including second cancers. These studies also need to be supported, but I think the easiest way is to do it that the health insurance systems should be obliged to fund lifelong follow-up of a treated cancer patients. In some countries it's done, in others not, but this would make a huge difference to the availability of good data with individual dosimetry. In the end, we are interested in individual dosimetry, and cancer survivor studies are expanding at the moment. At least I hope I see it right. And these will be able to provide a lot of interesting data on normal tissue effects and maybe even pregnancies after treatment.
So thank you for your comments. And I had another comment related to these studies, because there is an example from, for example, from exposonic studies in general. What people are doing now, they are providing like open protocols to use these blood samples in future for any even unknown from it now, but maybe in future new exposures, maybe new chemicals that are not discovered for now. So they have this tendency to have these open protocols. So if maybe it's good to be in synergy of these cohorts who are having data from before, you know, they're following like generations, like people, mothers before to be pregnant, when they are pregnant, their children. So they are like continuing for these cohorts already established, and they're collecting all data. And then just if they have this open protocol, just to put in synergy with them and get data from registries, from medical, I mean, not from accidents, but from medical exposure and everything, and combine. It could be good, maybe application of costs.
Question 15, which organs should be studied?
It's a whole body dose. I mean, to me, it's a whole body dose. So I'm not sure that question makes sense.
Say in utero exposure is practically always nearly whole body or a whole body exposure,
Right.
maybe some dose distributions, but anyhow, so
Yeah.
there are not specific organs which should be studied.
Right.
The organism has to be studied
Yeah.
for signs of disease or disorder or malformation or dysfunction. And then one goes, tries to find out which organ is causing this. One can't start with just going, we only send them to the psychiatrist and
Yeah,
they
yeah.
will sort out the problem.
Yeah. Anyway, I wanted to make a point, 2 points. One is that, Eric, while you're here, one of the things that our task group program committee has discussed, because we've had so many calls to set this up, is interesting is that we have uterine doses for, you know, the in utero cohort, and we don't have the fetal dose. So that's something, of course, we're interested in knowing if there might be interest in the RERF group, looking to see if they might be interested in relooking at that.
We're actually in the middle of a 2 or 3 year project right now called our organ dose working group. And we're working carefully with Wes Bolch at University of Florida and the NCI Chunsik Lee to investigate the feasibility of including modern phantoms into the DSO2 system. And we've made very good progress. In fact, several publications have come out already discussing the feasibility and how we go about doing it. But what we would hope to include would be pregnant mothers and fetus gestational ages of less than 8 weeks. And then I think there's 4 or 5 fetal phantoms, and then more complete adolescent, child, and adult phantoms, male and female, because we use hermaphrodite stylized phantoms now. So there it really would be a step up from what we have in the past. And we are very hopeful that we'll get that done in the next couple of years.
Yeah. So that's great news. And then 2 other comments about the developing embryo. The embryo just has a kind of cocktail party fact, you know, that we're all female before some of us become male. So women are always first. And the other comment about the gonad starts up high in the abdomen, and in normal people, it migrates down into the low pelvis. Sometimes it's arrested and doesn't get there. So when we think about dosimetry, and I know, Richard, you're interested in this and going back and trying to look at dosimetry, the fetus should have their the female gonad low in the pelvis and the male all the way out, outside the pelvis. But, there's a lot of variation. So it's really hard to really know the gonadal fetal dose, because in male fetuses, that even in term infants, when they're born from 38 weeks, onward, that's considered term, or 37 weeks even, they may not have their testes in the scrotum until 1 year of age. That can be normal. So, it may not descend fully until that 1 year age. So it's tricky to know where their testes are. For females, it can be all over the pelvis and they move. So, doing dosimetry on gonads, the fetal gonads, can be really challenging.
And just to general question 15, I would say a part of organs, we are speaking about IQ, no, it's not organ. So I mean, we should consider other effects, no, like psychological and other, more general, not only organs. When we are speaking, no, if we are speaking all effects, I've been other questions. Yeah.
There are psychological studies on outcomes on. Oh, okay.
Question 16. Compared to the state of knowledge in 2007, what is the contribution of new results and their potential impact on risk calculation effects of prenatal exposure?
Well, the only thing I can say right now, or the only thing I think we've said for question 16 is, deciding or, potentially discussing the CNS effect and how there may not be a threshold for IQ effect. That's, right. That's the only thing right now that we're considering for potential effect. Is that right?
Well, if you go back, I mean, in 2007, I mean, obviously we're talking about publication 103 there. Publication 103, as far as in utero effects were concerned, relied on publication 90, which is 2003. So essentially 20 years back. And you know, I think things have moved on. Certain things have been, if you go back and read, you know, publication 90, certain things have been clarified in that period of time. And a number of the studies we've been talking about have been published in that period. So it would be constructive to sort of look at publication 90 and the assumptions that were made there, and how we have sort of moved forward on certain aspects. For example, I mean, if you look at publication 90 and then publication 103, there was hardly any evidence from the bomb survivors irradiated in utero. Those studies, the incident studies and the mortality studies, have come since that time. So there are, you know, it is well worthwhile to sort of look at these, look at the assumptions that were made in 90 and how those things have changed. And I think there are a certain number of aspects where there have been changes, and we would look at things somewhat differently now. So that, you know, that's well worthwhile. I mean, one of the things, coming back again to the whole set of questions, is and I think this echoes something we were saying earlier. The value in actually looking at these old big studies. I mean, you're not going to be able to do these big, you know, these gigantic mouse studies again that we refer to, you know, that the Russells were up to, and others, you know, in the mid 20th century, and there is still, you know, quite a lot to learn from those studies. You know, I referred to the NCRP report and Bob Brent and his input into that. You know, Bob Brent was one of the you know, the guys that goes way back, and it is of value to look at these things again, because there are, you know, there are oddities thrown up by the experiment, the animal studies, the laboratory animal studies, the mouse studies. I mean, you know, people point to the mouse studies. Well, you don't really see much of an effect of fetal exposure of mice, for example, in terms of cancers, and that comes back, I think, to you know, the comparison, you know, mice and men sort of business again. You know, the gestational period of the mouse, of course, is much shorter, and the state of development of the mouse at birth is different from that of the human. So again, I think it's well worthwhile to look at these particular aspects again in some detail. But there you go.
Which are the driving mechanisms that should be explored to improve understanding of radiation-induced conceptus effects? Any comments?
Well, driver genes or driver mutations are often typically inferred based on the frequencies that occur in different cancer types or associated with different exposures. So if the mutation or if the gene is hit more frequently than expected by chance, this is considered as a driver, because there is apparently, it's a snapshot when you sequence the for mutation in a cancer or other tissue. It is a snapshot of the events that occur that presumably contribute to the clonal selection and expansion of the different clones. And therefore, if you see mutation more frequently in certain tumors, then that's how you kind of, it's accepted way of its driver. But of course, there are other, more functional based, let's say, to establish the driver. So this is basically in silico. There are in silico algorithms that can that are accepted to be a way to establish driver mechanisms. So I think this is something that is based on the genomic and epigenomic data, omics in general, that are part of this large sequencing effort, TCGA, IGC, and so on. So I think this is now acceptable. We used one and we established our own, which is pan-cancer multi-driver score. So it is published, it's been around, it can be used. But this can be linked to the radiation, of course. I think this is, and this is of course possible.
In what is mentioned there in the question 17, so we already discussed, let's say, the pathways and processes of systemic, local, and multi-organ effects, especially for the CNS, cognitive disorders. Growth retardation, yes. Epigenetics is still, I think, an open question. Dose dependence, it's also done. Type of tissue, yeah. Yeah. Maybe in terms of accelerated aging, we tried to follow this in animals, but so far we didn't see an effect on aging. But although there are some minor effects, but maybe it's also confirmed by the Hiroshima data that there are no major aging effects of the exposed population, except if Eric can give. Sorry?
Just related to this, actually, the aging, there are different biological clocks, as you know, telomere length and so on and so on. But recently, there is it is really quite spectacular. This epigenetic clocks, Horvath and others. There are several different clocks that are remarkable in predicting chronological age. But of course, there are examples, conditions where these clocks are accelerated. And I'm just curious about radiation. And this has been now established for many different risk factors, many different diseases. We established, in EPIC study, in European perspective study, that this clock is accelerated with breast cancer. But I'm just saying and there are many other clocks that use similar, using methylation patterns, and they're quite remarkable. And I'm just curious whether anybody looked in the context of radiation or different types of radiation dosage and so on. So, but that is something very, very interesting, because this is really like, biological clock. So it's,
So we are conducting an experiment with animals, but yeah, I think that would be much interesting to do it with humans, actually on the maybe atomic bomb survivors. And indeed, it's quite interesting data on the epigenetic clock. And we use also an animal model for Alzheimer's disease that we irradiate, and we can see an effect on this epigenetic clock. Indeed, it's very interesting. But yeah, so that it needs more, let's say, translation to human. Yeah.
I think some of the existing data can be used to test this question, because there's been a large epigenome-wide studies in the context of different cohorts, where there may be radiation or medical use or accidents and so on are actually included. So you could basically simply select for those that are for which the radiation exposure is a certain or available, and then see or you know, establish new ones. And then there are, I think, also the of course this is done on the kind of genome-wide profiling, but there are now actually more kind of targeted approach to target only those so-called CPG sites in a more kind of, so it's more kind of cost-effective way. If you really want to kind of establish the new, it's a kind of new study where you could collect perhaps more informative data on radiation.
That wasn't what I stood up for. When you mention this epigenetic and biological clock and changes that may or may not be due to radiation exposure, are you specifically talking about the in utero exposed, or would it also be, it seems to me, applicable for those directly exposed, for instance, the atomic bomb survivors, to see if there were changes. I'm specifically thinking about our adult health study, where we have longitudinal blood samples collected. And if this epigenetic clock is morphing over time, then it seems to me that that would be a, you know, a possible place where you might be able to start thinking about looking at that. But so I guess that was my question, because we see so little in the in utero to try and to do a new study and such, where there might be very little signal, seems difficult.
Yeah, so very briefly, it's not limited to in utero exposure. What Steve Horvath, who first established this, he actually get an idea that looking at the methylome data sets, and he collected like thousands and thousands, you know, the data sets collected in the context of different projects using the same technique. So it's all methylome Illumina array 450K. And actually he said, you know, I was gonna see putting, you know, trying to figure out which informative CPGs can predict the age, chronological age, okay? And then he found 340 CPGs when they just look at the methylation of status of these 340, you know, CPGs. And then he found that they can predict the age within the 3 months, within 3 months. So without knowing the, you know, if you just look methylome, you can predict somebody's age. It's just quite remarkable. I mean, this is overperforming the telomere length and any other biological clock by far. And then he had a problem to publish this. He said, nobody, it's too good to be true. He had really struggled a lot. And then, you know, eventually ended up published in Genome Research, no, Genome Biology, which is a decent journal, and it was cited and reproduced. And there are now improved clocks by several others. So, and then actually say, well, but that's expensive way, alternative way of birth certificate. You don't need to profile somebody's, you know, to get, you know, but then idea is really whether the clock is accelerated, you know, in different conditions, or deaccelerated, you know, with certain lifestyle improvements. Yeah, so I think that's, it's not, and actually he did not use the in utero, any in utero data at the time. It's just general population, but of course now this being applied to many, many different conditions, diseases, and so on.
Moving to question 18?
I suppose the I mean one of the great values of these mechanistic approaches, what we're going to be interested in terms of the next set of recommendations of ICRP and the reports that go into that is how you move from moderate to high doses, such as the bomb survivors, for example, acutely delivered, to the sort of low level exposure regime. And, you know, I cannot believe that that no one has been involved in some of these arguments as to how to interpolate down to zero dose or low dose rates for that matter. And we've already touched on this in terms of IQ score, for example. We've been talking about. I mean, is there a threshold, as there appears to be for severe mental retardation? And okay, we can appreciate that for severe damage to the central nervous system, the brain, that this might be confined to moderate to high doses, but perhaps if we look at something like an IQ score, maybe there isn't a threshold. Now, you know, it's going to be decent mechanistic models that it's going to tell you something about that. Is this a threshold effect, or is there something that goes right the way down to low doses, which is again going to be the one of the principal aspects of the next recommendations. How close or otherwise we might be to providing some sort of reliable inference from mechanistic models is another question, of course. Well, if anyone's got any views on that, I'd be very interested.
Anyone? People online?
There was a workshop, and you were part of that workshop in Japan for the individual radiosensitivity. And it kind of touched on animal models, and it looked at that lymphocyte, and I can't find the article, of course. No, I know. Hold on.
I just came back to confounding factors and other things, and I was thinking, actually, in the current world we are living in, and all this future generation live with other kind of exposure, like microwaves, PCFs, and even from blue screen of the, from mobile and from computers. Already there is associations with the cancer. So I think we should go even always maybe for this exposure, I mean huge models, to include all other possible risks.
I was filling in while Kimberly searches, but I in this general theme, and Klaus mentioned this. I mean, the real problem with medical studies, which is what I bang on about, and Klaus has touched on this. if people are exposed for medical reasons, it's because they're ill or suspected of being ill or have been ill. Therefore, there are a number of reasons why you should be suspicious of medical studies. You know, these are the things that are confounded by indication. In other words, you know, there's a patient has some condition which leads to a greater frequency of diagnostic exposures, but that condition also predisposes, let's say, to cancer. So you know, you have this confounding by indication, and then you have reverse causation. So there is a, you know, you have an early undiagnosed, slow growing tumor, which leads to conditions which require CT scanning, but it's a while before that tumor is actually diagnosed. So it was actually the tumor that caused the CT scan rather than CT scan caused the tumor. And it is undoubtedly, well, to me, it's undoubtedly the case that some of these not CT scan studies that have been reported over the past decade or so suffer from some of these problems. Just to illustrate, if you look at the Australian study, for example, all the tumors that they looked at had a positive effect, so a positive risk related to the CT scan exposure. Some significant, some not. But the only cancers that were negative, not significantly so, but had a negative risk associated with the exposure were breast cancer and lymphoid leukemia. Now, if I was to say a priori, which were the cancers that were going to show some effect, it would be breast cancer and lymphoid leukemia, and they were the only two cancers, including melanoma, Hodgkin's lymphoma, which showed a negative effect. All the others were positive. Now, to me, that indicates there's problems in there with reverse causation or confounded by indication. So it has been also for years. People have looked at the Oxford survey and other antenatal exposures and said, well, in actual fact, it's due to the health of the mother. The health of the mother is why they got these exposures, and mothers who were ill during pregnancy, their children are more predisposed to childhood cancer. So the argument goes, and well, okay, you know, there is some validity in that. So I say this because it is obviously important, particularly if you're relying upon studies of medical exposures, as indeed you are for childhood cancers following in utero exposures, that there is some backup of some sort from experimental data to produce some reliability that this is a genuine cause and effect relationship, which is one of the important aspects of experimental studies. I wish there were more of them to provide more definitive conclusions. But have you found your study now?
Yeah. So there are two sections that are of interest, and they're from the really impressive research groups. One RERF, but the others are QST in Chiba and so I wanted to just share with you that this was published in 2019 from the workshops that we held collaboratively in launching Task Group 111 on radio sensitivity. It's chaired by Simon Buffler, and it comprises an international group of folks. So, you know, I was just a person who attended this workshop, and have followed their work in reviewing literature on radio sensitivity. It's kind of an update of looking at the topic. Let me see if I can find. So, Eric, you may be able to help me, but Kei Yoshida wrote this section about longitudinal analyses of clinical data and biosamples. And he noted that there were, he talked about within individual variation over many years in peripheral blood monocytes and atomic bomb survivors. And he published one paper in 2019. And then he also talked about the adult health study showing inflammatory response that was elevated, but they have not been able to find, as far as this report, the cell source of this inflammatory response that's elevated. And so that's kind of interesting. And, you know, it's still elevated. So that's interesting. So they have various inflammatory markers measured in peripheral blood from that they assume that associated with the radiation dose. And it says, since previous immunological studies have revealed that aging phenotypes of T cell immunity were associated with persistent inflammation in A-bomb survivors, the study by Yoshida investigated whether radiation exposure promoted age-associated increase in peripheral monocytes, a mediator of prolonged inflammation. And they've been performing these blood tests since 1958. I won't go through all of it, but it says the relationship of increased monocytes along with aging phenotypes of T cells needs to be investigated further. So, and then the second study was looking at T cell receptors in healthy volunteers to compare, and I don't have a lot of information on that. But they've done a lot of animal studies to look at radiation response. And I'm sorry, I don't have the full information, but I think we should review this paper in relation to the stuff, because there are so many data, and it does look at perinatal exposures and cancer induction, and compares it to childhood cancer. So I think it's worth taking a look at this. I'm sorry I didn't have it in time to have it reviewed. Yeah, but I think we'll throw this one in there.